As an exposure, it's a big topic. It's big to squeeze in 1 hour, and but I catered it for this audience, so we get the most benefit. These are, I think they painted here. If I'm out, but I don't know what's. So, syncope is defined as a transient loss of consciousness, complete loss of consciousness, caused by transient global cerebral hyperperfusion, characterized by rapid onset, short duration, and spontaneous complete recovery. If you really get that definition right, that will help you a lot in diagnosing patients in the clinical setting. And we're going to go over each part of this definition. It's not rare. Everybody admitted patients with syncope. Everybody has a family member who had fainting spell. Annually, out of 1,000, up to 40 people will have syncope. Maybe a quarter to 1/2 of those will seek medical attention. 3.6, 3 to 4 will end up in a specialty clinic, whether it's cardiology or neurology or others. And only maybe 1 will be referred to emergency room. That boils out to about 1 million patients will present with syncope annually in the United States. About 1 to 6% of all emergency room visits are related to syncope. That's 300,000 per year. And 1/3 of those at least will get admitted to the hospital. And in the hospital, 1 to 3% of all hospital admissions, syncope is the primary diagnosis for admission. That's almost 100,000 hospital admissions per year, are more than $5 billion in annual cost. So, why do we faint? For syncope, as I said, it's cerebral hyperperfusion. The brain requires about 0.5 milliliter per gram of brain tissue of blood per minute to stay conscious. And any drop in that will result in syncope. That's translated in a patient who is an individual who's standing. You're going to need a no heartbeat for about 5 to 6 seconds at least. If you're in supine position, you're going to need a systole for about 8 seconds. But not just no heartbeat. Low blood pressure can cause syncope, and it's estimated that systolic blood pressure at the carotid level, if it drops below 60 at the carotid level, at the heart level, that will be enough to cause syncope. So cerebral hyperperfusion can be because there is no heartbeat, or blood pressure is too low, or other causes, oxygen in the blood, even with a normal blood flow, oxygen is too low. Several etiologies here we talk about. One, what's called reflex syncope or neural mediated syncope, and has 3 types. Vasovagal is the most common, but carotid sinus hypersensitivity, and what we call situational syncope, cough syncope or micturition syncope. This is the most common cause of syncope. 2/3 of all patients presenting with syncope are due to neural mediated or reflex syncope. Orthostatic hypotension as a cause of syncope is also very common. Cardiac arrhythmias, whether it's bradyarrhythmias or tachyarrhythmias, account for about 10-11% of all causes of syncope, and other cardiac or pulmonary illnesses, not related to arrhythmias. They can cause syncope by reducing the cardiac output, aortic stenosis, hypertrophic cardiomyopathy, acute PE, acute sudden drop in cardiac output. And there are things that can be mixed up with syncope, but they're not really true syncope. Epilepsy or coma due to drug intoxication or metabolic disorders, drop attacks, TIAs, or psychogenic syncope. And after extensive evaluation, there's still a small fraction of people we just don't know the cause of their syncope. And it's not really a secret that people with syncope have a higher risk of dying. That's really has been established a long time ago, but it's been confirmed in several studies. Actually, vasovagal syncope or neural-mediated syncope, it does not increase risk, but all other causes, whether it is unknown cause or neurologic causes, neurologic not means a big stroke or intracranial aneurysm rupture or something like that, not neural-mediated. And the worst prognosis is cardiac syncope. That is associated with significant reduction in survival. And those who present to emergency room with syncope, a major event will happen within 1 week in up to 15%, and mortality rate is 1% in those patients. And if it is cardiac syncope, mortality rate at 5 years is about 50%. At 1 year is 15%. So when they tell you the difference between syncope and cardiac sudden death, syncope you wake up, but it is, if it is cardiac syncope, that's a mini cardiac arrest and you consider it an EP. It's not something you take lightly. So how do we evaluate these patients? If you stick to the definition of syncope, where you take a good history and mediocre physical exam, and you really take a good look at the EKG, you're good to diagnose more than 60% in that encounter alone. And you will not need any more work as a cause syncope. Other tests can be needed. Echocardiogram is the most common, but ambulatory cardiac monitoring, electrophysiology EP studies, and mostly non-invasive tests can be required in a subset of patients, but uncommon. So, how to define syncope? As we said, it's the definition here gives you the tools to identify the cause and the real underlying etiology of syncope. So, first you have to establish that the patient really lost consciousness. And that means he was not aware of his surroundings, he's not aware of himself, and unable to respond to stimuli. So if the patient tells you, no, I was hearing everything, he did not think. Now, this sometimes could be obtained from the patient, but many times the patient even does not recognize he fainted. And this is important. When we do a head table test, the patient would faint, he would start seizing, we get the table down, he or she wakes up, and I would ask him, so what did you feel? Nothing. Did you faint? No. So some patients would go down and fall and do not recognize that they really lost consciousness. So you'll have to really be very deliberate in putting the information. If he just fell down, well, why did you fall? Did you trip? If there's no real cause of him falling down, then probably he did lose consciousness. So dig deep in that history. Now, if no loss of consciousness, then you can call it a pulse, or dizziness, or vertigo, or psychogenic pseudosyncope. And the other part of the definition is rapid onset and short duration. Rapid, that means it's within a few seconds of a prodrome, up to a few minutes. It's not having a prodrome all day long. And short syncope typically lasts for seconds to less than a minute. If it goes 2 to 3 minutes out, you're stretching it. More than a few minutes, you're talking about a coma. That's not syncope. By definition, syncope, you should wake up quickly. Cerebral hyperperfusion, if it lasts for 20 minutes, your brain is dead. So it's not something that lasts this long. So many times I will ask patients, when was the first chance you woke up? I woke up in the hospital. So all the medics coming, and that's not syncope. That's something else. And it has to be complete and spontaneous recovery. So if there are neurologic deficits, that's not syncope, that's a stroke. And if you have to intervene to get patients out of that, that's a cardiac arrest. If you have to do CPR or shock, it's no longer syncope. All that can fit 2 other problems that are not syncope. One is epilepsy, and the definition here, transient global cerebral hyperfusion. Epilepsy is exaggerated neuronal discharge. So epilepsy will cause a sudden loss of consciousness with a rapid onset and complete recovery, but it's not caused by cerebral hyperfusion. And also head trauma can cause cerebral concussion and what looks like syncope. But many times we need to dig deep to differentiate these events. When it comes to head trauma, you have to be careful because the trauma might be a cause of the fainting, but also might be a result of fainting and falling. So, how do we encounter the patient in emergency room or hospital or clinic? You have really to be structured what you want to know from the patient, and you have to pull the information. The patient will not know what's important to you. So you're going to need to ask about circumstances that happened, or in which that syncope episodes happened. Was he sitting or standing? Was he active? Was he walking or resting? Was it just after exercise or during exercise? Was it hot? Was he standing for a while in the crowds? Or is there some event that happened? He was getting a blood draw, or was shaving, or was turning around his head, doing driving, for example. And you're going to need to ask if there were prodrome before that happened. Did it happen all of a sudden, or did you feel it coming? Was it dizziness? How long? Is it just 2 seconds, or just happened immediately? Or you felt bad for a few minutes? Nausea and vomiting, and these vagal kind of symptoms are very important for the history and to diagnose the underlying etiology. Whether palpitations, chest pain, dyspnea, can point to cardiac syncope, but also can be seen in other causes. And for epilepsy, if there's an auditory or visual auras prior to the episode. And during loss of consciousness, you're going to need to ask many times the eyewitnesses. But did he slump, or kneel, or fall suddenly? If he injured his head, you know things are really sudden. That patient he could not even sit down or ease himself to the ground. Was he ill or cyanotic? And that's different. There's a difference there in the etiology. They have seizures. And what kind of seizures? Was tonic-clonic everything seizing or just myoclonic jerks? Did the seizure start at the beginning syncope or after? And again, the duration. Was it just seconds or minute or two? Now, maybe the duration, the patient does not remember anything until he's in the emergency room. Maybe because of a post-ictal state, he was confused. But the eyewitnesses will tell you, yeah, he woke up in a minute or two, and then but he was confused. Well, there's tongue biting, or was the eyes open and closed? And what part of the tongue biting happened? And that helps differential diagnosis as we're going to see in a minute. And following, when a patient wakes up, was it a complete recovery as if nothing happened? Or he was still dragged, exhausted all day long, nauseous, vomit, or sweaty? Did he have still just pain or shortness of breath? Was there a bladder or bowel incontinence? So let's go through one at a time. And cardiac syncope, as we said, it's either no heartbeat because of sixth sinus syndrome, long sinus pauses, or AV block, or very fast heartbeat that there's no cardiac output because of VT in a structural heart disease, or very fast SVTs. But can also because of drop in cardiac output regardless of the heart rhythm. And we see that with atrial stenosis, hypertrophic cardiomyopathy, acute PE. So usually, a syncope occurring during exertion is an ominous sign. And you have to really, really treat it seriously. A lot of heart problems, especially electrical heart problems, inherited from long QT syndrome to catecholaminergic ventricular tachycardia. These notoriously happen during exercise. Syncope in supine position also is important. That means there really was no cardiac output. It's not just a matter of a job blood pressure when you stand up. Or if there's a pause, it was long enough to cause syncope during supine position. Typically, cardiac syncope is sudden, and the patient has no time to go down. prodrome, yeah, I felt dizzy for a couple of seconds, then I'm fainted. And typically they might have some chest pain or trouble breath if there's acute PE, for example, or something like or acute MI, but they might just have a couple of seconds of dizziness and then they're down. And typically, if they're up and around, this will cause significant trauma to the patient. But they wake up very quickly. A pause of 15 seconds will cause syncope for 15 seconds. It's not going to cause syncope for 3 minutes. So if you're thinking of sinus node dysfunction and this 5-second pause, you have to really, really think hard to explain why does he faint for 5 minutes. That does not fit. He's dead by then if we really get no heartbeat for 5 minutes. Recovery is quick, and typically, once they wake up, if there is no underlying cause like acute MI or acute PE, just because of its arrhythmias, they're good to go. And we've seen events of patients, even with ICDs, who get PT and get faint, they get shocked, and afterwards they want to go and continue playing or whatever game they're in. You can pull some data from patients about heart disease, but also family history. Those who know heart disease, especially the young, especially those who have syncope during exertion, you have to dig deep in that family history of syncope and sudden cardiac death. Most of workup is structured around the family history, personal history, and clinical presentation, but also an EKG and echo are important. And ambulatory monitoring if the syncope is repetitive. If it happens every day, then you can get it with a Holter monitor. If it happens once a week, you can get it with an event monitor. If it happens once every 6 months or once a year, and the patient gets a cardiac accident with it, it's important for you to know what's causing it. And clinical history doesn't point you towards anything else. You're going to need to consider a blue recorder implantation. But if the clinical presentation in the clinic and EKG is normal, no past history of heart disease, you excluded 97% of cardiac causes. So in a young patient, no cardiac arrest, and it doesn't smell like cardiac syncope, his EKG is normal, really, his syncope is something, caused by something else. And that's important for prognosis also. The second cause of syncope is orthostatic syncope, and it's caused by orthostatic hypotension. Now, when we're supine, about 1/4 to 1/3 of the blood volume resides in the chest. Once you stand up, about 500 to a liter drops down to your legs. That causes reduced venous return to the heart, and stroke volume can drop by up to 40% in these patients. So blood pressure will immediately drop. The heart compensates for that, like your body compensates by the baroreflex receptors. These are receptors with the carotid and the aortic arch. Once they are stretched, kind of mediated, once the distension of those arteries is less, they send signals to the brain immediately withdraws the vagal tone and increases sympathetic. The adrenaline, increased adrenaline and decreased vagal tone usually will cause reflex tachycardia. Sympathetic tone also increases peripheral vascular resistance, venous and especially arterial, to preserve blood and push it to more into central circulation. So both increased heart rate, increased resistance will increase the blood pressure back to normal values. What happens to cause any impairment of this system will cause a problem with orthostasis. So it can be autonomic failure, whether it's central autonomic failure, like what we see in dementia or Parkinson's disease, that the reflex is not intact anymore. Or it's intact, but the peripheral nerves are not delivering the signal, especially to blood vessels through sympathetic drive. We see with diabetic neuropathy or drugs that impair it. Or maybe something non-neurogenic, body indication, whether it's anemia, hemorrhagic shock, or dehydration because of GI problems. Or maybe the whole thing is intact, but the heart cannot respond. You're increasing your heart rate, increasing risk of the heart cannot increase cardiac output. So you drop your blood pressure, heart rate increases, but in cardiac tamponade or severe aortic stenosis or KPE, the stroke volume will not increase, even to that. So any impairment in this kind of reflex compensatory mechanism will cause this to be the final result. But almost every mechanism in the orthostasis is associated with increased heart rate, and that's very important to remember. A lot of drugs we're familiar with, diuretics, alcohol, and the antihypertensive agents, will impair this reflex, but antidepressants, antipsychotic medications are commonly overlooked as a good cause of orthostasis. So, orthostatic hypotension is defined as more than 20 millimeter the drop in systolic pressure, or 10 the drop in diastolic pressure, or that's a good blood pressure drops to below 90. You have to have the patient in supine position for at least 5 minutes before, and you check blood pressure not immediately when they stand up. It is within 3 minutes. So after 3 minutes, you have to check blood pressure to see if there is a drop. And there are different types of orthostasis we'll go over in a second. Now, orthostatic syncope, they have to drop blood pressure and they have to faint, not just in a drop blood pressure. So you have patients with syncope in clinic, and yeah, he is orthostatic. It doesn't mean that that's what caused him to faint, especially if he did not faint in the clinic. Once you reach diagnosis, nothing really necessary. No workout is required. You might consider an observational test just to study how much and what's the time interval to the drop in blood pressure, but it's not typically required. If you do the observational test, there are a couple of types of orthostasis. One is we call the classic initial orthostatic hypotension, and it's caused by the pooling of blood in the legs, the 500 to 1,000 milliliter of blood. But another type, this is usually compensated, but with some delay to get to your back blood pressure. But another kind that blood pressure keeps dropping. We see that when you're on a plane sitting for a while or waiting, it's no longer pooling blood. There's extravasation of non-protein fluid outside the capillaries. And that can account for 700 milliliter, whether it's in the legs or in the abdomen. And that causes protracted orthostasis. And the body has to compensate by other mechanisms for it. Generally, it happens upon standing, especially if it's prolonged, or sudden change in postural from supine to standing. Also postprandial, because that's where the standing blood vessels dilate. After exercise, because all blood vessels dilate in the muscles, those can also cause orthostasis. Usually there is a prodrome of cerebral hypoperfusion, the blurred vision, the dizziness when they stand up or after exertion. And many patients, especially with that delayed orthostasis, will describe kind of that, what we call the coat hanger pain. Pain in the back of the head, neck, and shoulders. And that's because of the ischemia to the muscles there. Once they stand up and they're continuing standing, you always feel uncomfortable in this area. And that's a clue that there's significant orthostatic hypotension. But almost always, unless there are drugs to prevent that reflex, they have tachycardia in addition to the hypotension during period of loss of consciousness or orthostasis. But once you return to supine position, they usually feel well quickly. Patients who are prone to this are those with neurologic problem or peripheral neuropathy, whether it's diabetic or amyloid or something else, or those on drugs that can cause neuropathy or parasympathetic reflex. It's more common in elderly, and orthostasis probably happens in 20% of those above age 65. So finding it in a patient syncope doesn't mean it is the cause of syncope. It's very common. And yet in the young, usually the causes are non-neurogenic, not related to neuropathy or central nervous system disease It's more related to volume depletion for any reason or drugs. So how do we treat it? Initial hypotension or later neurogenic hypotension, acutely just give a patient to drink water. But we don't give him anything with salt or sugar. It's not juice, because if there is anything kind of edible, if you will, it will vasodilate splenic bed, and you really can worsen the hypertension with it. So you need just water if you want to give them anything. Not juice, not Gatorade. Counter maneuvers, pressure counter maneuvers. We will talk about it in a minute. But mitogen and fludrocortisone are the mainstay here, in addition to withdrawal of any drug that can cause the orthostasis. Once it's central autonomic failure, Parkinson's disease, or something like that, you can target it with certain drug. Now we'll come with to reflex syncope, and that's neural-mediated syncope. It has three types: vasovagal, carotid, or situational syncope. And vasovagal syncope is the most common. Most common cause of reflex syncope, most common cause of syncope, period. We call it neurogenic or common theme. Lifetime risk of each one in this room is about 4 out of 10. You will have one episode of syncope. It's more common in women than in men. And usually the first faint median age is about 14. And most of those will have had fainted at least once before age of 40. And it's very peculiar, classic presentation that you should not miss in clinic and over-evaluate the patient. It has significant relation to triggers, whether they are related to orthostatic stress or emotional stress. So standing in a line for a while that you drop anything to cause the blood to cool, increase sympathetic reflex, to increase heart rate. That's not because it's orthostatic hypotension. No, it is that triggered the neurocardiogenic reflex. After exercise, it's very common, especially strenuous exercise. That's in contrast to exertional syncope. Somebody playing basketball and during play he faints, that's very serious. Somebody playing basketball and he goes and rests and he faints on the bench, most of the time that's benign. And most of the time it's related to neurocardiogenic syncope. Central triggers: being afraid, fear of pain, or having pain. It's a very common cause to pain. And we see it a lot in the cath lab. When you stick the femoral artery, or when you hold pressure on the femoral, on the groin, your patients get a vagal response. And we are always in a balance between vagal and sympathetic nervous systems. And those are the systems that are controlling our heart rate, blood pressure, breathing, GI, bowel motility, and genital urinary functions. And typically they are opposing effects, but when it comes to circulation, we have sensors in the carotids, in the aortic arch, and in the cardiac chambers, and measure things like SVC that feels the pressure or stretch. That's kind of a measure of blood volume and blood pressure. And also there are some chemoreceptors that will send signal to the brain, and in the solitary nucleus here, where serotonin is a major factor for the interaction, they send signals out, whether it's vagal or sympathetic. So vagal is more so related to the heart, where it's affects the sinus node and the AV node, and usually it's a slowing effect. Sympathetic is the reverse, but sympathetic and adrenal reflex will also cause constriction of blood vessels, preservation of salt and water from the kidneys. So, when you have fear of pain, increased adrenaline, hypovolemia, or centrally mediated kind of triggers, you can get a reflex of increased vagal tone, and reduced sympathetic tone. This will cause vasodilatation and hypertension, and this will cause slowing of the heart rate. Then you get worsening hypertension and syncope, but because of the high vagal tone is not just specific for the heart, it's the same vagus nerve that supplies everything else. You're going to give the vagal symptoms, the nausea, abdominal discomfort, maybe vomiting, feeling exhausted, washed out for a while, even after the syncope, and being there for others. These are so pathognomic. This is difficult. That alone can give you the diagnosis. Again, remember, it's bradycardia, not tachycardia, that's associated with the hypertension. While orthostasis is always tachycardia or orthostatic hypertension. Few tests you can do, but most important for diagnosis of vasovagal syncope is clinical history. It commonly happens in upright posture because it's, at the end of the day, it's a drop in blood pressure. So if you're supine, not a lot of effects for a drop in blood pressure. That hydrostatic indifference point is around the heart if you're supine. So a drop in blood pressure is not going to affect the brain a lot. During hot weather or febrile illness, after intense exercise, or related to pain or scenes of injury, or during medical procedures, especially scoping the throat or the larynx, they're always autonomic prodrome. Most patients, I should not say always, but feeling hot and warm and nauseated before, that's very characteristic. And cerebral hyperfusion syndrome, dizziness and tunnel vision, is due to the hypertensive effect on the brain. During loss of consciousness, there are hypertension, but also bradycardia. So the medics arrived on the scene, they could not barely feel a heartbeat, and blood pressure was low, probably it's vasovagal. It's not that he's an AV block and caused hypertension. No. And so all of a sudden recover on arrival, but even at arrival in emergency room, still tired, still heart rate on the slower side in the 50s, and blood pressure barely 90. Patient feels very exhausted. That is vasovagal syncope. So one good test for this is the delta test. And we put the patient on a table and get baseline measurements of blood pressure and heart rate, then we tilt him at 70 degrees, and we're gonna need to reproduce what happens clinically. What's the balance between afferent and efferent pathways? So the test here, standing him up for 20 to 40 minutes, will cause relative hypovolemia, pulling blood in the legs. We can aggravate that even by giving nitroglycerin, sublingual, to cause vasodilation and pulling more blood in the legs. Adrenergic stimuli we can stimulate by giving isoproterenol to increase heart rate. Or we can stimulate CNS triggers by giving IV clomipramine, which increases intracranial serotonin. We don't really use that a lot. Then we wait for the reflex. And most of what we see that all of a sudden, patients start feeling warm and hot and dizzy, nauseous, and he faints. And that's associated with a drop in blood pressure, but also a drop in heart rate. The heart gets slower, coincidental with the blood pressure. Sometimes we call it cardioinhibitory if the heart the rate it drops very slow, 10 or 20 beats a minute, or very long pause. Or we can see vasopressor, the heart rate drops, but mostly the blood pressure is the culprit for the syncope. But always the heart rate at least will not increase. Most of the time it will decrease and significantly decrease. This is opposite to what we see with orthostatic hypertension or orthostatic syncope. Blood pressure decreases and heart rate increases as compensatory, but was not enough to compensate for the drop in blood pressure. POTS, postural orthostatic tachycardia syndrome, The blood pressure decreases slowly, but heart rate really increases significantly. Those patients typically do not faint because the drop in blood pressure is not severe enough. For vasovagal, both go hand in hand. Blood pressure drops and heart rate drops. The test has 70 to 90% sensitivity, and it's more specific, especially if we don't give a drug to induce the syncope. However, a patient with syncope, I tell him he faints, doesn't mean that caused his syncope. It has to really be similar in symptoms and the clinical situation that he had. If he developed now nausea, and he's about to vomit and sweaty and then fainting at the table, but at home, all of a sudden, probably he just prone for that, vulnerable to vasovagal attack, but it doesn't mean that that's what happened at home. So if the clinical presentation is very good for neurogenic syncope, we don't do that table. We treat as is. If this question, you really feel it is the cause, but you're not sure, or there is a convulsive component when I rule out, you can't do it. Sometimes we do it just to prove to the patient that we know what we're talking about. A mother who comes with her 20-year-old daughter who's been to a neurologist who diagnosed her with epilepsy and a few other doctors, and you come in a clinic and tell, there's nothing, there's no neurogenic, it's not going to believe you. Or you just increase your fluid intake. So this sometimes helps. Yeah, I review your symptoms, I know what's going on, and I'm going to treat it. And believe me, I have family members diagnosed with epilepsy for just vasovagal attacks. So once it gets to a neurologist, he has to come up with something.
Not a cardiologist.
No, we're never diagnosed with epilepsy. How many of you diagnosed with epilepsy? You never. Ambulatory monitoring can help, but you have to be really watchful what you're really looking at here. And patients reporting syncope with a Holter monitor, and that's just shows this. This is very interesting. A syncope with a slowing of the heart rate should alert me that probably he's vagal, and probably the cause of his syncope is a significant drop of blood pressure with some slowing of the heart rate. Most other causes of syncope, orthostatic causes, this should be tachycardia. To have a slowing of the heart rate during syncope should really give you a clue. You're talking about vasovagal syncope. Also, on a loop recorder or monitor, when you have this is not because its AV node is sick and he's getting AV block. Whenever you see the AV block happening with a slowing of the sinus rate, that's not an AV nodal disease. That's something affected both the AV node and the sinus rate. That's a vagal response. That does not necessarily he needs a pacemaker because it's intermittent AV block. No, it's a vasovagal syncope. So if you want to obtain ambulatory monitoring, you have to be alert that vasovagal, this is how they present. It can be just what you see here, slowing of the rate, or might go really into low pauses, whether sinus pauses or AV blocks. Typically, once you have vasovagal episodes, the risk of recurrence is about 30%. And it can cluster in some years and disappear for many other years. Generally, it's benign, but we have to be careful when we talk to patients about benign. Benign is, it's not going to kill you until you drop and fall on something hard. It will kill you. So the fainting part is not benign. The etiology is benign. It's going to happen to 40% of us in our lifetime. But this is a patient we admitted a year ago. That's a vasovagal syncope. It can really break your head. It can cause intracranial bleed. So don't take it lightly. Yeah, it's vasovagal, you're fine. So these patients really need special attention. So number one is you have to educate the patient. You have to explain it to them like I'm explaining to you now. What's the pathophysiology? What kind of triggers and prodromal symptoms? And you have to be sincere. Our management, we have few things we have to do. It's a trial and error. Depends on how you tolerate it. I'm probably going to adjust management a lot and give them a close follow-up. It's not just, I'll see you next year. I'm going to see you in a few weeks to see how. Otherwise, you're going to end up seeing you in a few weeks anyway. Because they're going to call your office 10 times until your nurse gets sick of it. You got to keep seeing this guy. And that's what happens. So schedule it. Schedule it and make sure that you see him frequently and you're concerned. And reassure them, never tell them it's in their head. Because they're going to go to another doctor. So don't minimize the effects. So it is a problem. It is a disease. It's have good prognosis. But it is a disease that I'm going to need to manage. So the first thing you tell them, once you feel it coming, and many patients have prodrome, go down. I tell them land peacefully rather than crashing. You're in Walmart, go down. Yeah, it's embarrassing, but much less embarrassing than waking up with a medic on the head in your head, just trying to get to the emergency room. Counter pressure maneuvers can help when the patient has kind of a prodrome of syncope. When they feel hot and dizzy and they feel it coming, now they know what it means. Crossing the legs, tensing the lower body large muscles can increase cardiac output. Squatting, isometric exercise with really tensing the arms, gripping a wall can help prevent the leg tone. That can abort kind of some of those episodes, or at least prolong the prodrome until patient finds something has time to lay down. I always tell my patients when you're in church and you feel that, it's not time to wait to walk out to get some air. You're going to drop on your way out. It's time to lay down. And I always tell his family, when he faints, the first thing is not to prop him up either, or set him up in a chair. Just prop his legs, not the head. You're going to need to stay hydrated. At least 2 to 3 liters of water a day is required for patients with a current vasovagal syncope, and too much salt. You have to have bond with that salt shaker. And if you don't like salt, you're going to need to go to thermotax. 1 or 2 with every meal. Some studies show that we can do some standing training or tilted training. 2 or 3 times a day, or that you stand against a wall and maybe 3-4 minutes initially, and every few days you increase the duration until you get to 30-40 minutes after several weeks, can help kind of increase your capacity to stand without triggering the syncope. So, though a patient to do that every day for weeks, that's very unlikely. So we go to medical therapy, and we remember there is a relative hypovolemia because of what's pulling in the legs. Induces sympathetic reflex, which goes to the brain and interacts with serotonin. Vagal reflex can cause the slowing of the heart rate and drop in focus. So we're going to need to counteract that. Relative hypovolemia, we tell patients to increase salt and fluid intake. We can use further cortisone to save salt. If patient is already eating salty food and drinking fluid, what else we can do? Beta blockers. We used to use it a lot, but very sketchy data about its efficacy. And the same thing with negative choppy agents. Diuretic agents, not used a lot like euhemobina. Usually they're not tolerated for chronic use. Serotonin uptake, we might, all these can be a second-line drug that you add. But if you want to add Paxil, or please explain to patients, not because he's crazy you're adding this, because they'll think they're using him for depression or anxiety. So I'm targeting this in the brain because, so explain the mechanism of the illness and why you're using the drug. Most effective, the drug is mitogen. So beyond increasing salt and fluid intake and probable use of Florinate, you're going to need to go to mitogen as your first agent. That's in addition to kind of lifestyle changes, modifications. And how aggressive you have to, it depends on the frequency of those spells. But nitrogen has been proven to be much better than increasing fluid, much better than beta blockers. Pacemakers require a very small subset of patients. Those are the patients who have very little prodrome and very low pauses documented in cardiac monitoring. And the pacemaker has a benefit in those. It's, for example, if you have patients whose heart rate starts 80, then he stands up or gets anxious and heart rate increases, then they get that vasovagal reflex, heart rate drops. The pacemaker is not going to pace him at 60, and no, wait till it. Once you see this kind of rapid drop in heart rate, it's 110 or 120. So it will compensate for any pressure hypertensive arm with a bigger reflex. So it can help with these, but it's only for patients in whom the syncope is documented to be caused by long pauses because of the vagal tone. And they have very little prodrome that they cannot lay down in time to protect themselves. Driving is an issue. It has never been documented that vasovagal syncope increases risk of car accidents. So typically it's not prohibited unless it's severe and refractory to medications. Once it's commercial driving, again, you just have to establish that you treated the severe form. Because it's very unlikely for vasovagal syncope, which is not situational, to happen while seated. Situational syncope, coughing, duration, or kind of pain, yeah, it can happen. But patients just spontaneously to faint while driving is very, very unlikely. They might get pre-syncope, dizzy, and feeling hot, but to faint completely, it's very unlikely. Situational syncope is the same reflex, but it's triggered by certain situations, coughing or micturition syncope. And these autonomic symptoms are present because of vagal tone in half of patients at least. And carotid sinus massage, again, carotid sinus sensitivity, again, the same concept. Those baroreflex sensors in the carotids are activated by head turning, shaving, or wearing tight collar, and there is sudden loss of consciousness, very quick recovery after a short duration of the syncope. But because it's very sudden, patients typically fall or have car accidents and significant injuries. Many times, especially in the elderly, patients who keeps falling for that's a trip. There were no steps there, and it's at home. They're walking every day to the kitchen, but they fall. You have to suspect that. And really, the answer is very easy once you know how to uncover it and remember to do the carotid sinus massage. It's rare in patients younger than 50, very common in those about 80, and especially in men. So shaving activates the baroreflex kind of triggers in the carotid sinus, and that will increase the vagal tone. Carotid sinus massage, you can do it whatever you want. There's one or another. But just watch that you're going to need to push against the carotid sinus, push way up under the jaw angle. And it's a 5-second continuous push with a little massage to trigger those. Listen to the carotids first, because if they're brewing, and you do that, you can show a microemboli called source. The response you're waiting for, either a systole or a drop of blood pressure. So carotid sinus hypersensitivity is defined as more than 3 seconds. Pause or more than 50 millimeter mercury drop in systolic blood pressure. Patients can have either or both. But again, if that's the cause of syncope, you have to reproduce the symptoms. So typically, we'd like to do it while the patient is not so fine. You want to patient will tell you, yeah, that's exactly how I felt. That will prove it, not just having a pause. 40% of those above 80 years old will have a pause. It doesn't take a lot. If you reproduce the symptoms, the patient feels the same way, that's what we're going to give you the diagnosis. And really, I have patients who've been through all tests, and it took just 10 seconds to give the diagnosis. Once you remember, this is kind of a possibility. And most of the time, pacemaker is a treatment choice because there's no time for any modification from that split of a second to protect the patient from falling down. Now, I'm going to go through a couple of things here. Syncope mimics, and I think that's very important to differentiate. If there's loss of consciousness for a long period, it's a coma, it's not syncope. But also we have to differentiate it from epilepsy and TIAs. If there is no loss of consciousness, we have to differentiate it from pseudosyncope, drop attack, or cataplexy. So, seizures or convulsions during the episode does not take anything. During tilt-table testing, 4 to 8% will have seizures during that episode. In blood donor clinic, where you're going to have a lot of fainting, a lot of patients will start seizing. So a seizure is a hypoxic brain injury. I mean, you can have seizures in vasovagal attacks or any other syncope, cause of syncope. Doesn't mean it is epilepsy. And actually, misdiagnosis rates of epilepsy because of syncope, 13% of those in epilepsy clinics, they really had syncope, not epilepsy. And sometimes we get referrals from the neurology clinic with those with epilepsy refractory medication, and they end up having syncope because typically it's a long QT syndrome with runs of polymorphic QT causing them to faint or intermittent complete block. Usually it's a cardiac syncope, there's no prodrome whatsoever. So most of those with a questionable epilepsy end up to have cardiac causes, but also we see vasovagal episodes causing with very short warning period. How to differentiate? Well, there's a prodrome with syncope, but it's uncommon with epilepsy. What you get an aura and a cry, the prodromal cry at the beginning. It's important to know that the convulsions or seizures during a syncopal episode, usually it's brief, usually it's myoclonus, and usually it happens after the patient faints. While those with epilepsy seizures start immediately, that's why they cry, because they're contracting all their muscles, it's with the air out. So immediately it starts with the loss of consciousness. When they are out, they're breathing deeply and heavily, not a patient with shallow or absent breathing like syncope. Tongue biting, when it happens here, it's the tip of the tongue, by the way, and the side of the tongue with epilepsy, just related to muscle contractions. If you try to open their eyes, for syncope, it's fixed or upward deviation of the eye. It's lateral deviated and syncope. So these are clues. If it happens in front of you, just happened in postcap just 2 days ago. So to help you to see what's going on. No post-ictal phase in syncope, while it's very prominent in seizures. If a patient tells you, yeah, I fainted, I fell, I injured myself, and a minute later I'm up around, yeah, I know everybody around me, I remember the medics coming and asking me questions. That's not epilepsy. Epilepsy, they have to be out, confused at least, not able to remember their surroundings for at least 15-20 minutes. So no epilepsy if patient wakes up immediately after syncope. You can rule it out completely. Why patients with syncope are pale because of loss of blood flow to the brain and head. These are cyanotic patients with epilepsy. So some clues help you. Now the most important thing is the TIA, which is really overestimated in this population. It's very, very rare for a stroke or a TIA to cause syncope. And if it is, it's usually in the vertebrobasilar region. Never a carotid disease will cause CTD that you have a complete recovery with. For loss of consciousness, you have a stroke raising half of your brain from a carotid region to lose consciousness. And once that stroke happens, you're not going to recover in a minute or two. You're going to end up half paralyzed. In vertebrobasilar, because it supplies the brain stem, it can cause it, but that's the only distribution of vascular disease to cause syncope-like. So as a practical rule, TIA is characterized by focal neurologic signs without loss of consciousness. Syncope characterized by loss of consciousness without focal neurologic signs. There's even nothing sharp between the two components. So don't mix things, and you're gonna go to emergency room and hospital admissions. We're gonna get the EEG, we're gonna get the neurologic consult, we're gonna get the head CT and MRI, and they're expensive and frankly useless. They're even not indicated, but I guarantee that 90% of patients admitted get all those. If you stick to the medical history and you know that patient lost consciousness and recovered quickly, no hospital data, you don't need anything of these things. Mic long. So only if there's head injury or two seizures that you're not sure, you might consider them. But not for the routine workup for carotid Doppler, you're never going to get for a patient with syncope. It means nothing. Even if you find disease, it just means nothing. But lastly, I'm going to talk about psychogenic syncope. A patient face in front of you can be a kind of conversion disorder, but can be lingering. And what do you do in these situations? A couple of clues. These patients never had an injury. They always ease themselves to the ground when they faint every day 3-4 times, but they never had a bruise or a head trauma or broken limb. And if they happen before in front of you, blood pressure and heart rate stays stable. You can do a top table or loop recorder. But when it happens, a couple of things you can do. First, painful stimuli. Once you really tension heart, they tend to withdraw. That means consciousness is present. And drop test. Hold his hand above his head and drop it. Usually they will not hit their face. They drop it on the side. Eye opening. Try to open your eye. Usually it's tough because they want to avoid looking you in the eye. And even if you manage to open your eyelid, usually the eyes roll up so they don't look at you. And give away weakness. If you want to see how weak they are, they will pretend they are weak. So these 4 clues to tell you if the patient who just fainted in front of you, is it real loss of consciousness or not? There always comes one way or another to find out. Cataplexy, hyperventilation syndromes, mechanical pulse, and drop attacks. This is not very well identified kind of entity, and also, but these are rare. Once you stick to a history, you'll be able to diagnose most of these patients in the clinic. I'll stop here. Thank you very much.